Mhm. Hey, welcome everyone to our AMS Grand Rounds for this month. It's a real pleasure to introduce Dr. Jen Unwin tonight, who will be speaking about ultra-processed food addiction, the essential knowledge that clinicians and health providers need to know. She's a UK-based clinical health psychologist who has over 30 years of NHS experience, specialising in behaviour change and food addiction. And she's well known for her work alongside Dr. David Unwin, who is a GP in the UK, and also her husband in supporting type 2 diabetes remission through low carb approaches. And she's also the author of a wonderful book called Fork in the Road, A Hopeful Guide to Food Freedom. So we're really thrilled to have her with us tonight, and we appreciate her efforts in being with us on a morning over there in the UK. So please join me in welcoming Dr. Jen Unwin.
Thank you so much. And thank you, Deepa, for that really nice introduction. Yeah, good evening, everyone. And thank you for taking the time to come and listen to me talk about my favorite subject, ultra-processed food addiction. And just to give you some sort of essential bits of knowledge, and then hopefully you'll be interested in maybe following up and learning more. And I'll talk about that as well. So I'm hoping to talk for about 30 minutes. So we've got time for Q&As at the end. So let's get going. So this is what I'm going to try and cover. So what is addiction and how can that apply to food behaviors? And what is the expert consensus on this topic? A new paper just been published. How prevalent, how common is this problem? Depending on the client group that you're working with, patient group, and how might you recognize it? What are some of our ideas about what causes this problem and how you can help, what strategies you can help your clients with, or where you might, you might point them to as well. And then hot off the press, the 12-month follow-up results of our intervention study. It's just been published in Frontiers. And then, as I say, some ideas about where to go next if you're interested in this area. So I hope you'll be able to hear this. Let's have a little listen to Sergey, who was signed up for our intervention study, and he's going to tell you what it's like to have a food addiction.
How would I describe living with food addiction on a daily, weekly basis? Just in one word, a nightmare. That's all it is, just a nightmare. Feeling of being helpless, feeling of you're just completely out of control. Just this urge comes and there's nothing you can do about it. You feel like there's nothing you can do about it, and it's just it takes you places that you never thought possible.
So what you hear there is that sort of hopelessness that people experience around this problem. You know, that they've tried everything and these cravings come and they just can't control them, and that utter hopelessness. But the good news is that Sergey did take part in our treatment study, and he's been abstinent from sugar and ultra processed foods for the last 2.5 years. So it was a happy ending, and he's very cheerful now. So I'm just going to move so I can see. So according to what are we talking about here? What's addiction in general terms? So according to the American Society of Addiction Medicine, addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and individuals' life experiences. And people with addiction, here's the killer, use substances, in this case, we're talking about food, or engage in behaviors that become compulsive and continue despite harmful consequences. Right, where's my clicker not working? There we are. So what happened was that we made an initial application in 2022 to the WHO to recognize food addiction. I think we called it food use disorder at the time, something like that, as a sort of clinical condition that could be diagnosed in the International Classification of Diseases, the ICD-10. And some of you will, I don't know what you use in Australia, where you can perhaps tell me later whether you go by the ICD or the DSM for mental disorders. So the DSM is the Diagnostic and Statistical Manual, and is hosted by the American Psychiatric Association. So there's another group in America that are currently making an application to the DSM to recognize this condition. But in Europe, we tend to use the ICD. So we made a bid to the WHO, and they rejected that at the time, which we thought they would, but we thought it would be interesting to know what their arguments were. And one of the key arguments was that, you know, there's no consensus around this topic, so it's too early to recognize the condition. So we thought, right, well, let's see if we can make a consensus. So we over a year approached 51 experts. It was basically anyone we could think of who was either researching or practicing internationally in this area of food addiction. So we approached 51 people, 40 people accepted, so doctors, dietitians, nurses, psychologists, researchers, etc. And we ran a series of workshops in a sort of, there's a method called the Delphi method, which is a way of trying to get consensus amongst a group of people. And we facilitated those, and we're trying to sort of pull people together around some key questions and see if we could get consensus. And we were really delighted to get consensus between 37 out of the 40 participants, and this is probably going to come out this week in Frontiers. It's been accepted for publication. So the key consensus points was that there is enough evidence to justify this new substance use disorder. There was a lot of debate about the name of this thing, and people have variously said sugar addiction, carb addiction, food addiction, ultra processed food addiction, processed food addiction. So there were, you know, several competing sort of strands of arguments, but everybody could get behind this idea of ultra processed food addiction. That tends to be where it starts. Those tend to be the problematic foods. And it kind of points the finger where the finger should be pointed, if you like. So people could get behind that. And there's most research about that as well, about ultra processed foods being addictive. The symptoms that are the symptoms of substances of abuse are the symptoms that described ultra processed food addiction, and we'll go through those in a minute. Given that we're going to accept that ultra processed food addiction is a substance use disorder, it follows that the mainstay of treatment for that would be abstinence from, in quotes, drug foods, just in the same way as that if someone had a substance use disorder for alcohol, the mainstay of therapy would be moving towards abstinence from alcohol. So food addiction exists on a continuum like any other problem, and overlaps to quite a degree, as you'll see, with eating disorders, but is a separate condition. And people also agreed that recognizing the disorder would lead to more treatment options. So that was an exciting thing to be able to pull together, and we hope it'll sort of move the field forward somewhat. So when I say that the symptoms of food addiction, I'll use that shorthand, are the symptoms of a substance use disorder. Here are the ICD substance use disorder symptoms, 6 of them, and you need 3 or more for it to indicate a problem. Obviously, it's not a diagnosis, but a screen would be that if you have 3 or more of these symptoms, that would indicate a problem with whatever substance we're talking about. Heidi and I have come up with this acronym that we use in our work because it helps us to remember the symptoms. So this applies to food, but it also applies to alcohol and cigarettes and other drugs. So C is for compulsion, powerful urges to consume, and those cravings where you heard Sergey talk about that. R, we've got us reaching for more, and this picks up the idea of tolerance, which we recognize in alcohol and other drugs, that you need more and more to get the same effect. That's exactly the same with sugar and processed foods. Activities neglected and ignoring what you've once valued. So, thinking less about hobbies and friends and family and work, and focusing more and more on obtaining or thinking about or recovering from the substance, in this case, food. Volume is having more than you intended. So saying to yourself, for example, I've bought this packet of biscuits because the kids, the grandkids are coming around later. I'll just have one quietly with a cup of tea before they get here, and you end up having 7 or the entire packet. Is for exclusion. This picks up the idea of withdrawal symptoms that people do experience when they, as we all know, when we're helping people give up sugar and carbohydrate, people can get quite a difficult few days there with various symptoms like headaches and shakiness and gastrointestinal problems, sleep problems, but also low mood or anxiety. And the killer symptom of addiction is always continuing to use despite knowing it's doing you mental or physical harm. And this is what David calls intelligent people doing stupid stuff. And I think that's the best summary of addiction. Why do people who know that this isn't a good thing to do carry on doing it? Addiction is that explanation. So in terms of how common is this problem, the best paper is really this large meta-analysis of studies using the Yale YFAS, the Yale Food Addiction Scale, which is the most commonly used scale, certainly in research, which is based on the DSM symptoms. And they found overall that 14% of the general population could probably be considered to be food addicts. But obviously in clinical groups, you get a much higher rate. So, for example, binge eating disorders, you're up in the 50%. There's this one study that, practically says 96% of people with bulimia, food addiction, compared to 14% of controls, and this high prevalence in people with type 2 diabetes, which makes perfect sense, really. So those of you that are working with people with metabolic ill health, it's likely that a really good sized proportion of those people are actually suffering with a food addiction problem. And of course, it's really important that we address that, otherwise they keep relapsing and can't stick with the advice. Pretty scary that the rate in children and adolescents is at least as high in adults. And of course, it's higher in overweight and obese children. And most people with a food addiction will tell you that it started very early, myself, but also many of the people I talk to, it's kind of people's first memories. They're 4 or 5 when they remember losing control over the food, craving food, trying to sneak and get foods, that kind of thing. So just to hammer home the issue, the sort of link with type 2 diabetes. So food addiction, people with food addiction are 7 times more likely to have type 2 diabetes. And there's this kind of dose response relationship between food addiction and diabetes, but also mental health problems. So the more ultra processed, the more people are food addicted, the more likely to have metabolic health problems and mental health problems. So we've got quite a big problem in the UK if you take that 14% prevalence, and it's probably contributing to a good deal of these chronic worsening health conditions that we're seeing epidemically, diabetes, obesity, etc. I don't know what the population is of Australia, but you guys will be able to work out your total problem. This is just to make the point, really, that yes, of course, ultra processed food addiction is linked with obesity. That sort of makes logical sense, but it's not always the case. So about 11% of people with food addiction are actually underweight, because there's also a link with the eating disorders like bulimia and anorexia. There's some overlap there. Sometimes people turn to very controlling mechanisms to try and manage their conditions. So it shouldn't be assumed that everybody with it's not a perfect relationship, obesity and food addiction. And it's a good reminder that also people can be extremely fit. So this guy is some kind of international Ironman. Some people may have heard of him. Ironman champion. And he said he had such a problem with sugar and carbohydrates that he had to sort of book himself into rehab. And he talks about how he had to wake up in the night to eat 3 times during the night, granola bars and things like that, which is the kinds of things that our patients talk about. So he was making himself extremely unwell. And we all know examples of athletes who are metabolically unwell, and because of this encouraging of them to eat sugar and carbohydrates as part of their training, you know, those with that vulnerability genetically or psychologically may get themselves into trouble. So how might you think about recognizing this in your clinic? So I'm going to talk about quickly the Yale Food Addiction Scale, which I briefly mentioned, Craved, which is our screening tool, but also just gentle inquiry, which is what David tends to do. So the Yale Food Addiction Scale, largely used in research, translated into many languages, thousands of papers using this study, and it's based on the DSM-5 criteria for disorders, substance use disorders. Quite a long questionnaire, but there is a short version, the MYFAST-2. If you want to look at it properly, you can just put MYFAST-2 into Google, and it takes you to the page with all the files there, and you can look at the questionnaire and the scoring. The scoring is pretty tricksy. Even when we were using it for research for the MYFAST, we were trying to get our brains around it. There's no way when I was a practicing clinical psychologist in the NHS, I could have scored that in clinic. It was just too mind-bending, really. But useful for research, and there's a children's version available. That's a bit tiny, I apologize, but you can see that there's these 13 questions, and then you rate from never to every day, and it's things like my eating behavior caused me a lot of distress, from never to every day. And they're asking about ultra processed foods like sweet, starches, salty snacks, sugary drinks, and so on. The Craved is based on the 6 criteria that I went through with you before from the WHO. And we're basically asking those 6 questions, whether it was yes in the past month, yes in the past year, yes more than a year ago, or no never. And this allows us to see over time whether people have as sort of improving. So if it's yes more than a year ago, that symptom is in remission. If you haven't had that symptom for 12 months, you're in remission. So if I filled this in now, I would be a food addict in remission, because I've been abstinent from my drug foods for well over a year now. But people first coming in, if you'd asked me this 10 years ago, I would have been 6 out of 6. So this we think is more useful in the clinic, because you can literally just ask the questions or get people to fill in the questionnaire. It's dead easy to score. You're just looking, has someone got 3 or more yeses, would indicate a problem that might then start a conversation. What's interesting is that when you ask people whether they think they have food addiction, they're actually pretty good at knowing whether they are or not. When we did our study, we recruited on social media, and we just said, do you think you're addicted to certain foods, and would you like to take part in a study? And all the people who applied to the UK part of the study who thought they were food addict did screen positive for food addiction. We didn't get any false positives. So you can ask people gently, do you think you're addicted to certain foods, or does it feel like, it's often bread and this kind of substance. David will say, they can't stop eating bread, they tell him, and he'll say, does it feel like that bread's like a bit of an addictive substance for you? Is that how it feels? And they'll say, oh my God, yes. Does it feel like 1 is too many and 1,000 is never enough? Any addict of any color will recognize that as their absolute experience. I just put this photo in of these Mars bars here to show that they're actually marketing that chocolate bar as a kind of cure for withdrawal symptoms of sugar, because grumpy, knackered, fuzzy-headed, and sluggish are all withdrawal symptoms from sugar and carbohydrate. And obviously, yes, you can cure that if you eat another Mars bar. But I just found that rather awful and amusing. So what's going on? How is it that sugar, carbohydrate, ultra processed foods can be addictive? You know, why do we lose control of our relationship with those things? So sugar and carbohydrate and ultra processed foods, those foods are designed, really, they're actually the food companies actually do studies where they put people in scanners and look at their brains as they feed them whatever it is, the Pringles or the milkshake, or and they're looking for foods that literally light up the reward centers of the brain. So yeah, we're all a bit doomed from that point of view. So what happens is that we get these big boosts of neurotransmitters, particularly dopamine, which is the reward motivation neurotransmitter, but also serotonin, which is the kind of happy neurotransmitter. We get these sort of unusually high levels stimulated by these not real foods, not foods that our brains were ever exposed to as we were evolving. And the brain's response to those high levels is to think, well, such high levels of these neurotransmitters, we need fewer receptors for those substances in the brain. I hope you can see that's a bad idea, to have fewer dopamine receptors and fewer serotonin receptors, because it means that your set point when you're not consuming that substance is going to be lower. And I think this explains those links with anxiety problems, depression problems, because the set point and availability of dopamine and serotonin is reduced the more of those sugar highs and ultra processed food highs that we have. So we get into a low mood situation as the norm, our sort of new setting. And of course, that's going to increase the cravings and compulsions to eat those substances that are previously given as that boost. And it also explains the tolerance effect. So we need more and more to get the same effect, because we've got fewer and fewer brain receptors. And it takes a few weeks once we stop eating sugar and ultra processed food. I mean, it doesn't take too long, but it does take some time for the brain to sort of reset and reopen a few of those dopamine serotonin receptors. And that's why people need to stay abstinent, because if they then have some more of their drug food, they get a really big hit, because the brain receptors are reconnected. They get a really big hit of dopamine serotonin, and that's very reinforcing, and round you go again. And this is why people do relapse, because if they have a little bit, it causes that relapse problem. So ultra processed foods are hyperpalatable. The other thing that happens when that reward center is activated to that extent is it suppresses frontal lobe activity. We think this is probably a sort of survival thing, where when people had to go out hunting for food, it was a good idea if they didn't think too much about how dangerous that was. So we forget why we shouldn't be eating those foods in the moment. When we're cued and we see the advert for McDonald's or whatever it is, frontal lobe suppression, dopamine flowing, we think it's a great idea to have the McDonald's in the moment. It's only afterwards we get that regret. I think the brain's a very mitochondrial organ, very energy hungry. I think if we eat this poor diet, we're damaging the energy in the brain, and I think we reach out for the sugar and carbohydrate to, in some way, try and sort of give ourselves that sort of boost, that we're not fuzzy-headed, as the chocolate bar says. And we all know that negative reinforcement happens when a negative feeling state is relieved, so we feel better temporarily, so we're more likely to repeat that behavior. So a number of mechanisms that we can talk to patients about. I also think that people are often literally undernourished, so they're craving more food and they end up eating the wrong food. The thing to take from this slide, if you look right at the top where it says liver. This is how much liver do you need to, does an adult woman need to eat 3 times a day to get basic vitamin requirements, and it's 7 grams. So if I ate 21 grams of liver a day, I'd be good for my essential nutrition. And if you look at the bottom, refined grains, I would need to eat 4 kilograms of refined grains 3 times a day. I'd need to eat 12. I mean, it's mind-boggling. 12 kilograms of grains to get my essential intake. So if people have a very grain-heavy diet, they're actually probably malnourished to some extent. So probably very many people walking around malnourished, so craving more food, feeling hungry, and actually still, probably not getting the right foods. So what does it look like when someone's sort of eating for recovery, eating to look after their brains? It's a typical diet that you guys would recommend. Real food as nature intended, nutrient dense, plenty of protein, plenty of good fats, and eating on a regular basis, at least initially, being a little bit cautious with too much fasting in the early days, because we're just trying to regulate the brain and the hunger. But it's not all about food, so that's the bit that we would easily be able to advise people on, because people have been using food to manage their emotions. They need to find other ways to do that. How are they going to get, I talk about getting your daily dose, how are you going to get your dopamine, oxytocin, serotonin and endorphins in a natural way that doesn't involve relying on food or other addictive substances or behaviors. And so that's a really great conversation to have with people. And really the one that hits everything is exercise or activity, particularly if it's done outside. I mean, exercise is brilliant for dopamine, serotonin, as I say, especially if it's done in sunlight, which you guys get plenty of. Endorphins you get from exercise as well. And if you happen to be exercising or walking with your dog or a loved one, you can hold hands, maybe not with the dog, but you can hold hands and get some oxytocin as well. So thinking about with people how they're going to incorporate getting feel good back into their lives is really important as part of recovery. I think we've got time to...
Learning about the addiction cycle was a real eye-opener, yet so blatantly obvious, and knew that I had an issue with food, with certain types of foods, with overeating. But I'd never considered myself to be an addict until it was right there staring me in the face.
So Karen had a binge eating problem, and again, she's been in remission since she learned that if she abstained completely from her drug foods, the brain would recover, and she found other ways to soothe herself, and she's doing really well as well now. Okay, so suggestions for dealing with this in the clinic. So you can screen using Craved or Gentle Inquiry, and then it's working towards abstinence. So that's the thing that you have to sell to people, really, and people really understand about alcohol and the fact that you'd abstain from that if you'd lost control of your relationship with it. So it's encouraging them to work towards that. Some people go cold turkey, some people go step by step, but whatever their individual drug foods on, trying to avoid them. So obviously a real food, high nutrient dense food plan, which makes sense. And it's not about dieting, it's about, healing the brain, giving the body the nutrition that it needs. It's absolutely no good having a cheat day, as I've already explained why. Sweeteners, also a bad idea, still light up the brain, still bad for the microbiome, still sweet. But can be used in transition to get people off sugar, but then people have to come off sweeteners. And I've had quite a few patients who've had more difficulty coming off sweeteners than they actually had coming off sugar initially. Not about weight loss. Explaining to people the addiction piece, and also explaining that addiction is one disease, many outlets. It's the same part of the brain, so they may also have problems with, and again, I've had patients who've also had problems with alcohol, nicotine, caffeine, shopping, exercise addiction. So it's about understanding addiction in general and then applying that But going with a harm reduction model of taking the first thing first, the worst thing first. So if someone's actually got an alcohol addiction, you're going to do that first, and then probably up to them then whether probably nicotine next if it's cigarettes, and then food, and then and you get the point. Nuts, cheese, and dairy are real foods, but they do cause problems for people who've already got this reward center problem, particularly dairy. And ongoing support is super, super important. So just quickly then, this has just come out in Frontiers. We did a study with three centers. We had a very similar program, and it was based on what you've heard about, really. Participants were self-diagnosed with food addiction, but they got a 12 to 14-week online intervention with monthly follow-up and support. We did the screening with them. We talked about the kinds of foods to eat, and then we talked about how you sort of basically stay in recovery and don't have slip-ups, and if you do have slip-ups, how you deal with it. And we were delighted, amazing, at 12 months. So this is the first ever food addiction treatment study that's reported 12 months outcomes. We still had 62% remission in 12 months at those that completed. Here's a bit more data. So top left is the CRAVE score, as you can see, coming down below the 3 cutoff in all 3 centres. The Yale Food Addiction Scale, a similar sort of thing, and then the Warwick and Edinburgh Mental Wellbeing Scale going up significantly during the intervention and kind of staying up. So mental well-being improved as well. This is a nice little graphic. So this is the Yale Food Addiction Score, which is obviously the main sort of internationally recognized outcome. You've got before in the left column and after in the right column. The dark purple is severe food addiction. So you can see we did have people at the beginning with quite severe clinical problems. And as you can see in the 12-month column, so many more people in the light blue, which is no food addiction. So the approach that we used is an effective treatment for food addiction. Yes, I wrote this little book in lockdown, and the second edition is about to come out, slightly updated. Forking the Road, you can get it on Amazon, and obviously recommend it to clients because it contains all this knowledge. If they're willing to read a book, that would be a good resource. And exciting news, we've got a 2-day International Food Addiction and Comorbidities Conference in London. We had the Consensus Conference last year, just 1 day. We're having 2 days in London. I know it's highly unlikely any of you are going to be in London on that date, but you can join us live stream, and you'll hear some amazing speakers. Nicole Avina, it's very well known in the space. Georgia Eade, the amazing Georgia Eade is coming. Dr. Tro, David will be speaking, etc. So lots of fun. It's a bit small, the Scan Me, but if you go to the CHC/conference, you can find the tickets, or I can send a link. So it would be great to see some of you there. And then I think that's it.
Thank you, Jen. That was excellent. Really enjoyed that talk. So much information in there for all of us to take away, especially in screening our patients and then commencing a well-supported treatment program. I would love to open the floor to questions, and I can see Anthony's right off the mark. He's had his hand raised since the actual talk was going on. So we'll go to you, Anthony, if you just want to... Sorry, I'll just make it so that you can unmute yourself. Yep, so you may now unmute yourself and then take it away.
Great, thanks, Deepa. Hi, Jen. In fact, really enjoyed that. Jen, just a couple of questions. Hopefully, they're not too lateral. First one is it possible to tease apart hypo or low blood sugar, or that roller coaster of, say, hypo, low, and high, insulin resistance, etc. through the day? and addiction? Is it possible to tease that apart? And the second one is, do you have any experience there with the NHS and now or ongoing with childhood trauma and food addiction similar to, say, other addictions, food, alcohol, nicotine, and other drugs, etc.
Yes, what great questions. Yes, so I think with the hypo issue, yeah. So we know, don't we, that if people are eating these high sugar snacks, high sort of hyperpalatable food type snacks, they're likely to get insulin, sugar high, followed by sugar crash. And I think that's another mechanism by which then they try and make themselves feel better, because that's a really averse sort of feeling, isn't it? That I know I used to get that a lot, that sort of shaky, low energy. You think you're going to basically need to sit down, you go a bit sweaty. And that is relieved, obviously, by re-eating sugar, or like the Mars bar says, you're going to feel better if you eat this. So I think that can be another driver for people. And they really notice, as well as you all know, that if they start eating this real food, nutrient dense, low carbohydrate diet, that those highs and lows go away, so people get this sort of steady energy. I don't know about the hyperglycemia, what link I would make to that. But just probably similar mechanism, really. But in terms of adverse childhood experiences, absolutely, like any addiction, where there are adverse experiences, that's another factor that can lead into that vulnerability to developing an addiction problem. And I usually say it in the presentation, but I didn't say it. Sugar's obviously the only psychoactive drug that we give kids. We don't give them caffeine, nicotine, alcohol as a rule, but all kids these days have access to cheap, ubiquitous, sugary drinks and snacks, so can use those to moderate negative emotions. Now, David Wiss, who collaborated on our paper, is really hot on this, and he'll be talking about that. He's got a paper on adverse childhood experiences. I should have said I'm hosting a special issue of Frontiers in Psychiatry on food addiction. The papers are just coming in now. I can send the link, but I think there's only about 6 of the papers that you can actually see at the minute, but there's going to be about 14 coming through. And there's one on adverse childhood experiences by David Wiss. So yes, that's definitely a factor. And what we usually say is a bit like any other addiction. Probably you need to try and help them sort of get that addiction stable, and then see what's left psychologically. Often people improve really vastly with their mental health once they get the food under control. But some people will then need, if there's issues around previous trauma or ongoing issues, then they may need some additional psychological or mental health help.
Yep. Great. Thanks, Jen. Thank you.
Vanessa, we'll go to you.
Yes, thank you. Good to see you, Jen. Thank you for the presentation. Hi.
Thank you for coming.
So many questions, but I'll try to be brief just with one. So, when you did your, I think, 10-week program, did you sort of, what order did you do it in? Did you first focus on the food and getting people abstinent, knowing that, abstinence is not necessarily a linear path, right? It can sort of go 2 steps back, 1 step forward. Or did you maybe teach them skills first so that then it's easier to stay abstinent? And then my second question is, in your study also, did people that you looked at, that you followed up after 12 months, did they continue doing support groups throughout those 12 months, or did they not do anything at all and then they were still abstinent? Thank you.
Great questions. So the order we personally did it in was we screened them for on Craved, and we got them to reflect on, you know, when did those symptoms start, what was going on around that time, you know, did it start very young, you know, were there times in your life when there were maybe other things going, when, you know, when did the symptoms sort of add in over your life. So we sort of got them to reflect on that, and I think that's a really useful place to start, because it gives you that chance to sort of think back about the condition that usually people are probably trying not to think about. So we did that, and then we talked about addiction quite a lot. So I think to sort of get people on board with the idea that yes, it's an addiction. It's almost like you have to get people out of that denial to accept it, because then they understand that they're working towards abstinence. And then we talked about the food and the fact, you know, certain foods have this addictive sort of potential, but you know, it's not all foods, you know, because people often say, oh, it can't be food addiction, we have to eat, you know, it's not like we have to smoke cigarettes or we have to drink alcohol. Well, yes, we do have to eat, don't we? But we don't have to eat chocolate bars, and we don't have to eat McDonald's, which are all modern inventions. So if we think of a sort of ancestral whole food diet, that's not going to overstimulate the reward center. So then we talk about the food, and then we start working with relapse prevention. You know, what if they're having slip ups, that like what was the run up to that, what can you learn from that, what would you do differently next time. People often really struggle with how I'm going to talk to people, how you sort of negotiate this thing socially. You know, what do I tell my friends about the fact I'm not joining in with coffee and cake morning, or you know, I'm not accepting their amazing thing that they've baked for me. And those are sort of real genuine struggles for people, that they can really trip them up. So working with that, so it sort of goes in that order really: acceptance that it's an addiction, education about the addicted brain and how that works, why abstinence is the treatment, and then working towards that. In terms of who did best, yeah, the people who engaged most in the support seemed to do better, but there were some people, and you'll have probably experienced this as well, who just get it, go off and do it. But it is more unusual with a proper addiction problem. You know, it's much more usual, because that's going to be a lifelong problem, and sometimes people sort of feel they've got it, and they go away and do it, and they have this sort of honeymoon period, and then something happens like a birthday or Christmas or a cruise, and they slip up for some reason. Or there's a thing where people think, oh, I've got it now, you know, I've got this nailed, I can cope with a bit of whatever it is, and yeah, and then the rest is history. So, but yeah, those who engage in support, I would say, are going to do a lot better.
Excellent. We'll go to Ron.
Right. Thanks. That was great, Jen. I love the chart on the micronutrients in liver and animal products compared to the plant products. 4 kilograms. 4 kilograms of grains, wasn't it?
4 kilograms of grains 3 times a day.
Oh, that's easy. My question's about your comment, or what you wrote down about caution with fasting. So if you could just expand on that. I encourage a lot of time-restricted eating, missing breakfast. I mean, the pretty common sort of thing. Sometimes the 1 meal a day options for people with type 2 diabetes, which seems to work very well. So what's the issues there with doing that and the caution with fasting?
Yeah, it's more just in the beginning, really. People have often had a history of sort of restriction and then overeating. They've extreme dieted and then sort of lost control. So it's trying to get this idea of sort of getting in a regular eating pattern without restriction, because if people continue to think of it as a diet, they'll never maintain it lifelong. People often get to the point of two meals, or even 1 meal a day, eventually. So it's only caution with it initially. Sometimes what people do when they come off a fast is that can trigger overeating. So you wouldn't want people to be doing like, 48-hour fast, that kind of thing, because it's usually as they come out of the fast, that's a vulnerable moment where you are pretty hungry and maybe your defenses are down and there's something available and it ends up in your mouth, and that can trigger other problems. So it's not that time restricted eating would be contraindicated for all time, and in fact, as I say, most people that I know do end up probably eating in a window of 2 meals a day. That's a metabolically advantageous thing to do, and it's good for the brain. It's just that initially we don't say you have to do that. We say, it's absolutely fine to eat 3 meals a day. We definitely say try not to snack in between, because you're just thinking about food too much then. Or if you allow snacks, then what snacks at what time. It just is too much food noise, and you're trying to reduce the food noise for people. So set meals are good. I mean, some people do end up sort of even weighing and measuring what they have, although we don't encourage that from the outset, because again, it's a bit too much food thinking, food noise. But sometimes people end up having to do that. So I don't know if that's a...
Yeah, I mean, I guess the issue I see is many people believe 3 meals a day is really healthy. Breakfast is the most important meal of the day. 3 snacks a day is really healthy. I mean, that's what we've been telling for the last 40 years when we brought in the high carb guidelines. So what we're doing is, the diametrically opposed. And when you sort of say, no, you can miss a meal, they sort of say, oh, is that all right? Because I'm not really hungry in the morning. I'm not really, but I just wait.
Exactly. We say to people, if you're not hungry, why would you eat if you weren't hungry? That's the signal. It is when you're hungry, eat this nutrient dense meal with the proteins and the fats, and then get on with your day. or just get on with your day if you're not hungry in the morning. Absolutely. Yeah, we would say that to people.
Thank you.
All right, we'll go to Liz next.
I'm Liz. Thanks very much, Jen. That's lots of food for thought. I also have a couple of questions, and I'm going to start with an easy one, like how much cheese is too much? Cheese is protein and fat, and those things tend to be satiating and self-limiting. I did a protein audit of what I eat. I don't normally weigh and measure, but very occasionally, once a year, I do. And one day I consumed somewhere between 200 and 250 grams of cheese. My second question is, do you find processed meats to be drug foods? And I ask because there was that article in The Guardian the other day about ultra-processed foods, and they reported on a study which said, oh, processed meats. And I'm thinking ham and bacon and biltong versus, say, chicken nuggets. They're very different kinds of things. So I just wondered, have you ever come across someone who's got a processed meat addiction? Like, do you see people who are addicted to bacon, for instance? Again, these things tend to be satiating and hence self-limiting. And the third question is in relation to low-carb substitutes for the common drug foods. In your recent article, you mentioned that the common ultra-processed foods that contribute to ultra-processed food addiction are pizza, chocolate, chips, biscuits, ice cream. And there are low-carb substitutes for most of those things. And there's the harm minimization analogy, which is methadone. And I know a health coach who talks a lot about methadone as the analogy. And I wonder what your opinion is of, for example, fathead pizza and things like that. And I'll stop now.
Yeah, great question. No, that's great. Brilliant questions. And really the answer is it's individual to all three. So to cheese, processed meats and substitutes. And in fact, they probably go in that order. So in terms of substitutes, that's the kind of thing that people start drifting to, so a hardcore food addict would start to think, how could I recreate my favorite thing as a low carb thing, and they, that might include sweeteners and so on. So we really discourage that. And what happens is that you tend to find that out for yourself, because it's the natural state of an addiction, that it's a bit like a leaky boat, and the water's trying to get in. So when we see something online that says, oh, you can make, healthy, like you say, fathead dough, then we're going to think, oh, that's great, because I used to love pizza, so I'm going to make myself pizza. Now, for some people, they could do that and not be triggered to eat more, not have cravings the next day, not want to eat it for every single meal, not feel bad after they eat it. That might be the case. But for other people, eating a substitute of what had been their drug food would be enough of a trigger to trigger off cravings for other foods and sort of cause a bit of a cascade of problems. So my answer would be similar for processed meats, would be, a sort of in quotes clean bacon or processed meat that didn't have sugar in it and other things could well be fine. I eat lots of bacon myself. That's something I can do well with. So again, that's something that people have to experiment for themselves, because they're all different. Again, the dairy. So lots of people with a food addiction problem do tend to start finding that they can really overeat yogurt and berries, for example, or they can really overeat cheese. But again, it's individual. So I always say to people, well, can you have a reasonable portion of that and then get on with your day? Or can you have that as part of a meal and not be going back to the fridge and wanting more, or feeling bad, or just overeating to the point? Or does it start off cravings for other things? So if I have cheese, I can just keep eating it, and also it will start me craving for other things as well. So again, that's a bit of an individual issue, that, and you're just sort of allowing people to come to those conclusions themselves about what is abstinence for them. Does that include dairy or not? Does it include nuts or not? Does it include 90% dark chocolate? Does it include fruit? Those are all things that people have to sort of figure out for themselves eventually.
Excellent. I'll just go to Nikki, who's in the chat. She was asking, do you find any use in supplemental tyrosine or phenylalanine? And her second question was, what are your thoughts on organic acid testing for neurotransmitter levels?
Not my area of expertise. I know there are people who do recommend certain amino acids. Who's the lady who's done lots of work? She might be Australian, actually. There's or New Zealand, a lady who's done a lot of work in this area. It's
Julia Ross.
That's it, Julia Ross. So I have read her book. I don't, because I'm a psychologist rather than nutritionist, so I'd have to work with someone else who knew that. I think if you're eating enough proteins and good fats, but yeah, I'm not going to comment because it's not my area.
All good.
I could say something not based on evidence.
No problems. We'll go to Lucy now.
Hi, Jen. Thanks for that talk. I've got two questions. One is, what are the criteria that separate out the people with binge eating disorder who don't have food addiction?
Yes. So binge eating. So food addicts tend to have very specific foods that they want. They're kind of, in quotes, drug foods, as we've already called them. People with binge eating disorder would, when an overeating episode starts, they'll eat anything to excess, and it's more of a sort of emotional, I just need to be kind of eating almost as a dissociation, as a distraction, or almost as a sort of health, a sort of self-harm thing. And people with food addiction, it can be much more like kind of grazing, keep going back to foods, fantasizing about one particular food, and it's sort of romancing, when everyone's gone out later, I'm going to sit down and have this sort of tub of ice cream. So it's more sort of, the kinds of foods that are eaten, and the way and the function of it, and the way that they're eaten. But there, as I say, there is this big overlap, because a lot of people with binge eating disorder would also have a sort of food addiction type problem. They've been trying to control the food addiction problem, and then it ends up with being a binge because they at some point will lose control. So
Yeah. And I think that seems to be and I think you mentioned this in your paper about just some discourse, I guess, in the management of people with binge eating disorder, where the overarching thing is don't restrict, there's no bad foods, all that stuff.
That's never going to work for a food addict. Yeah.
So okay. So I'm happy then that you've given me some good criteria on how to separate those two things out. The second question is, and I'm not sure if this is your area of expertise either, but the GLP-1s seem to have a lot of effect on food noise and where they fit in your treatment protocols.
Yeah, that's really an interesting new development, and certainly David has for some patients who just can't get into abstinence, prescribed a low dose of GLP-1s to get them going, to get them, they still need to understand that that's what they're working towards. And of course, you can't stay on those drugs forever. So you do need to be working towards some sort of sustainable way of eating. But for people who are really deep down in the food that can't climb out on their own, and we haven't got residential programs or anything like that. So he has been using that. I think the problem will be there's lots of people buying those drugs and taking those drugs who have no idea they've got a food addiction problem. So when they stop taking them, all the problems are going to come bouncing back, and the weight's going to bounce back on. And we know that there's other risks. I mean, there's some serious risks, but there's also muscle loss, and they end up in a worse position than they than they started. So it's a complicated one, but they probably do have their uses temporarily for some people, because they do exactly that, as you say, turn off that food chatter, which is so distressing to people.
Okay, thank you.
Are you going okay, Jen? Are you right for a few more questions?
Yep, keep
Excellent.
going.
All right, we're off to Carla.
Thanks, Jen. That was a great talk. My question's about when you're working with someone who wants to lose weight as well as deal with their food addiction. I know, like you were talking about the fasting and the restriction and stuff, and I find like it's a really fine line to walk. And I'm just wondering, do you have like a time limit that you say you need to be abstinent for, X amount of time, and then we can start talking about that? Or is it individual, or how do you manage that?
That's such a great question. Very individual. And of course, when people have been dieting and kind of obsessed with their weight their whole life, they're not going to give up on that very easily. But what we do try and persuade them to say, let's use this different lens. Let's use this addiction lens. Let's get that stable and stabilized. And what we tend to find is that the weight sort of comes along for the ride. It does come off. So people in the study did lose significant amounts of weight, and that's what David and I found with his patients, that if you can just address that food addiction issue and get them eating, as you all know, get them eating this real whole foods as nature intended diet, that the weight tends to come off. And then it would be an individual thing. If they've done all that and they're still not losing weight, I usually then say go into the dairy question, because quite oftentimes if people aren't losing weight, it can be a overeating cheese, butter, and nuts is another one that people tend to overeat those things, cream and nuts and dairy, and obviously because they're very calorific. So I know David then might go into, right, can we, can you try and just cut those things out for a while, and let's just see if the weight starts moving on again. Yeah, so it would be an individual thing.
There's no kind of baseline, definitely don't do it before like X number of weeks or months or something.
Well, I would say until, yeah, I don't know that there's a definite line, but you'd want a good solid few weeks of stability, I would think, in eating and abstinence. Yeah.
Thank you very much.
Thank you.
So Jen, I've got a question, and I want to frame this in the context of a case, or it's actually a lived experience of a colleague of mine. So she posted this question. So does anyone use any supplements or vegetable powders to boost the nutrition of their kids' foods? And any ideas for healthy lunchbox foods? So the situation that she's experiencing is that she has a 5-year-old who is a fussy eater, and this is one of my questions. Where does fussy eating come into it with food addiction, particularly in children? So that's the first question. So in her efforts, she's trying to ensure he's getting vitamins that he might be missing, because she's watching that he's a lover of Easter eggs, muesli bars, pretzels, and custard pouches, which are all, as we know, ultra-processed foods.
And not of any nutrition at all. Yeah.
Yes, and unfortunately, at the moment, the strategy that she's using is to promise the child to add one of these options to his lunchbox daily if he will eat the fruits and vegetables that are packed. And that strategy does not seem to be working so far. So it's this concept of using UPF, high sugar food, as a reward. And how does that lead into?
And then he's going straight for that thing first, probably. So, I mean, what I'm hearing there actually, and again, this isn't my area because I don't work with children and I'm not a nutritionist, but I'm not hearing about protein there at all. How do you build a body and brain? It's what we say to the people that we work with. Bodies and brains are made of proteins and fats. They're not made of fruit or custard, although there might be a little bit of egg in the custard. So, to build a child's body and brain, you're going to need proteins and fats. So it's encouraging them to eat that rather than fruit and then I mean, I suppose as a parent you're the one giving them access to whatever it is, and it's keeping your nerve, isn't it, that if they're hungry enough they'll eat a hard-boiled egg or some scrambled eggs with cheese or an omelette or something, and it's keeping your nerve if they're sort of turning their nose up at that temporarily. But I'm not going to give any more advice because I don't work with children, so I don't want to say something that that wouldn't be right, wouldn't be individual advice. But I mean, hopefully they can find a way to not use food as a reward, but maybe something else that the kid values, something like an outing to do something that they like. Or I just flashed up something about autism, and it's true, we get a lot of people in our treatment groups, actually, particularly women who are on the spectrum. So we get a lot of people with sort of autistic traits who have struggled with, I'm not saying that this is the case in this case, but that they do sometimes go together, that people are struggling with, because there's a dopamine issue often, and a rigidity issue. So we've had a few women, particularly in our treatment groups, who are adults with ADHD or autistic spectrum problems.
Yeah, it's really fascinating, I think, that what happens in childhood, seems to shape then the behaviors that are seen later on, and often people are not supported very well at an earlier age, so it sets them up for some of these problems down the line.
Maybe we have that genetic sort of vulnerability. I know my mum for sure was a food addict, so we've got that genetic vulnerability, but then we also learn all about food and how you eat, in the family and the broader families and the schools and so on. Of course, the nutrition there isn't often brilliant either. And then there's also this potential idea that the bottle the bottled milks, and I was definitely bottle fed, they had a lot of sugar in them, and they still do. So if we had that tendency to be triggered to be addicted to sugar, we were getting it as babies. And even in utero seems to make a difference. Someone's written a paper on that as well, that it makes a difference what mums are eating as well, what their diet and metabolic health is like.
To Alex now.
Hi, Jen. Thanks for the talk. My question was around naltrexone. Do you or David in the clinic have any experience with using naltrexone for food addiction, or know of any sort of papers around that?
I don't. I mean, it's an interesting question. It probably has been done, but I don't. David's never mentioned that, so I suspect not.
Thank you.
Okay.
Excellent. There's just a comment from Carla in the chat box. If kids are fussy, make sure they're given foods that are the texture they like, as this is often an issue as well. So thanks for that comment, Carla. That's really, really good. Now, it looks like the questions have finished up, unless anyone wants to desperately pop up their hand. While I'm waiting for if there's any last minute takers with questions, I just wanted to take a moment to thank Jen for sharing with us her vast experience in this area and all the work that she's doing, and also congratulations on elevating the discussion around food addiction and truly getting this as a classified and diagnosable condition, because that's been a large part of the work that you and others have done and continue to do in this space. And that really helps us all as clinicians and health providers to be able to discuss this with patients as an actual condition, which has been really tricky to do in the past, I think. There has been, it was just a thank you from Ron. So I wanted to also just plug the next 2 grand rounds that are coming up, which are actually going to be fantastic to follow off Jen's grand round that she just presented. So the next one's actually going to be by psychiatrist Zoltan Sanyai on Thursday, 29th of May, and that's going to be on keto diet, randomized control trials for serious mental health illness. And then after that, we have another psychiatrist, but from the other side of the world, Georgia Eady, and she'll be presenting in June, on Wednesday, the 26th of June, on nutrition therapies for mental health. So we're in a real sort of mental health, cognitive behavioral strategies and other things around food and the way we eat and engage it with our environments. And I think this is a fascinating area and a hot topic of discussion for all of us, and helps us build our skills. So thanks once again, Jen. It's been wonderful to have you with us tonight. This recording will go up for everyone after the probably the next day or two, once we get that all up and cleaned up with the editing. And then we hope to see everybody else at the next grand rounds. See you all soon.
Thank you. Thanks, Jen.
Thank you.
Bye. Bye.